All right, so it's good to be back. Limitations of this talk is I'm just only scratching the surface. That this is a very, very complex topic, and I'm only going to touch on a few aspects, and I'm building on the same talk that I've done last year, and I won't repeat some of the stuff that I talked about then. But even putting these talks together, there's still, I'm sure, much more that I haven't even began to talk about. So why bother with POCUS pitfalls? There's a lot of enthusiasm for POCUS out there for good reason, because it's amazing and it's very helpful. However, there is unclarity about how good one has to be able to sort of roam free and use their ultrasound machine to make assessments and decisions. And so some people, including cardiologists, are very worried about people without formal cardiac training willy-nilly making diagnoses, whereas other people, the end users, are saying, well, I'm not a cardiologist. There's no need for me to do all the things that you do. I just have to be good enough, and I'll leave the more complex stuff to you. And so there's a little bit of a tug of war between cardiologists and non-cardiac POCUS users. I'm sort of in the middle, being in both camps. And so I specifically have interest in this subject. What does it take to be a good POCUS user, and specifically not a dangerous one? Because ultimately, if we make mistakes with POCUS, it's the patients that are liable to suffer. So that's the last thing that we want to do. We want to help them and not harm them. So I organized this talk sort of going through the main objectives of hemodynamic POCUS and talking about things where we could go wrong in assessing these objectives. So talking about problems with LV-RV function, effusion, fluid responsiveness. I'm only mentioning it because it has been discussed, but I talked quite a bit about this in my last year's talk, so I won't go back to that. But I will talk a little bit about pulmonary hypertension assessment, which is a plus or minus. Again, some people argue that this is outside of the realm of POCUS assessment, but more and more, I think it will become part of routine assessments, especially with appropriate training. So I think it's important to know. So, starting relatively simple, this is a frequently encountered scenario. You try to get apical four-chamber view to do an assessment, and you get all this lung interference. So it can be pretty hard to figure out the function if you don't see the walls completely. But what you can do if that's the case, you can essentially slide your probe an intercostal space down or up, and also slide it to the side. So generally slide in the direction of the ventricle you want to see. So if you want to see more of the left, you slide lateral to the left. You want to see more of the right, you slide medially to the right. But this is a normal function. It's just, even if you can't do anything and that's all you get, you can still kind of be reassured that the walls, at least these walls, are moving reasonably okay. But I would caution people that one view is never enough. So if at all possible, unless we're in an arrest situation or something very dire, we should always try to see more than one view. So another useful component of the evaluation is the movement of the mitral valve. In adult cardiology, they have the standardized EFPSS number, so how close to the ventricular septal wall the anterior tip of the mitral leaflet is. In pediatric, this is not standardized as far as I know, but it still can be useful. You see this poor little mitral valve here is barely flapping open and closed, whereas if it were more closer to normal, it would go much more anteriorly towards the interventricular septum. So if you have sort of like, you're not really sure because you're saying, okay, maybe this is moving, not so bad, this is not so bad, but then you look at the mitral valve and it's barely opening. And so that it can be another useful hint that the function is pretty bad. So I looked at the talks that have been given this year in the POCUS channel, and excellent, and I'm very happy to be part of that. And so I went through some of the methods that were discussed and trying to talk about some of the potential pitfalls and complexities that can be encountered in using some of these methods. So fractional shorting is one such method that was discussed. And so essentially you look at the percentage change in the ventricular dimension from end diastole to end systole. You can use M mode or 2D, and you can use parasternal short or parasternal long. So the advantage is it can be relatively easy, and I say relatively, you'll see in later slides, is not always that easy. Relatively rapid, again, not always, but I'm focusing on the disadvantages of the method. Namely, it assumes no regional wall motion abnormality. And so, it used to be thought that mostly adults are the ones that deal with regional wall motion abnormality, functional coronary problems, etc. But the more I do this job, the more I realize that in kids, there's very often regional wall motion abnormalities. And I don't think we understand, or at least I don't understand very well why that is, because it's not necessarily a coronary artery pattern. It's just, I think it has to do mostly in the post-cardiac world where I live, has to do with minor injuries to the conduction system, perhaps subclinical forms of bundle branch block or whatever have you. But dysynchrony is actually quite common. So fraction shortening, I would very much caution against it. The other disadvantage is that it only reflects circumferential fiber shortening. So if the LV contracts in multiple ways, not just in one. So for example, and I'll show in a later slide, you can have good circumferential fiber shortening, but in longitudinal direction, it does not squeeze very well. It depends on LV geometry. So like we have our hearts in the cardiac unit are seldom normal. They can have like a more circular shape, or they can be smaller or larger or what have you. So that is not taken into consideration. And then of course it's operator dependent. So even though fractional shortening is touted as useful, clean and quick, I don't particularly think that is so great. So in this case, you have a parasternal short axis and you have your M mode through it, and it's actually pretty good perpendicular orientation right between the pap muscles. So this looks good. But when you look here, you're supposed to trace this and this like that to calculate the end systolic and diastolic volume. It's a little bit hard, and you can argue, okay, which line am I going for? Am I going to this line to trace the end systole? Am I going to this line to trace end systole? And it can actually matter. The intraventricular septum is much more crisp, but the posterior wall of the LV is not so crisp. And so it can be useful, but there's so many caveats that I think it's in the ICU world is probably not so helpful. This is another example where this can be deceiving. Imagine, this patient is actually not even congenital. It's a baby that had severe COVID myocarditis. She ultimately passed away actually. But so this is the recovery phase of her myocarditis. And if you were to do an M mode through here, you'd say, oh, this is great. I mean, look at how it squeezes in the middle, but you can appreciate how grossly desynchronous the motion of the intraventricular septum is, and how most of the good function occurs in the middle of the ventricle, and the apex is kind of ballooned and sort of like hanging out. So this is very abnormal. So if you were to just look at the shortening fraction through here, you would miss all of that. And of course, you notice a little bit of pericardial effusion here as well. So I would say no here for that. An example of what I was just saying. So parasternal short, when you're cutting right through the middle, the function looks great. I would say there's no issue here. But then when you look at apical 4, again, you get to realize how abnormal this is and how the apex is completely hypokinetic, as compared to the middle segment of the heart. And this is myocarditis, so I don't have a good understanding of why this is so desynchronous. Again, I think it's microscopic injury to the to the electrical conduction system. That's the best I can come up with. Okay. This is the same thing. Okay. Other possible caveats when we're looking at function, it's a technical problem. So we can foreshorten the LV here. So you're not supposed to be seeing the apex and parasternal long axis view, but you should see a little bit more of the LV here. So see, the LV looks kind of like round, and you see a lot more of the RV than you're supposed to. So this makes any sort of like fractional shortening or whatever estimation incorrect, because you're not catching the ventricle in the correct orientation. Here is an apical view. You know, you can get a false impression that this ventricle is hyperdynamic, which in fact is probably not the case, but what's happening is we're foreshortening the apex of the ventricle, and the ventricular cavity is like almost gone by the end of systole, but it's not necessarily because it's hyperdynamic or empty. It's just because we are foreshortening it, and so we're sort of probably more posterior than we need to be, and so the heart essentially disappears by the end of systole, and so that gives the impression that the function is better, like more active than it needs to be, and the ventricle is more empty than it is at the end of systole. So this is a slide that I used last year, but I kept it because it was a good illustration of what you can deal with in sort of daily practice. So this is a baby in the cardiac ICU where the baby wasn't doing very well. So I try to just do a quick function check, which is probably one of the most common reasons why you'd ever want to do a POCUS exam. And so this is apical 4, believe it or not. I can't even show the RV at all. It's all fuzzy. And you again can see this very dyskinetic movement of the septum. It doesn't look so good, but I can't quantify. I can't really say. Parasternal long axis is sort of probably worse. I mean, this is the mitral valve, and I know the LVOT is here just by virtue of knowing anatomy. I don't actually see it. And then, so the apex is somewhere, I'm not sure, somewhere. So, and then subcostal, you see short axis view. And so again, we notice that this kinetic movement of the septum and the function looks a little bit better here. But either way, it's really hard to know, I want to know, is it like really bad? Is it moderately bad or what? And I can't tell based on these things. I can tell it's not normal, but that's not really too much. And so what do we do when you really have fuzzograms? Everywhere you look, it's just fuzzy. So the tiebreaker is VTI, velocity time integral. So that is something that I use a lot, and I'm using more and more as time goes on. But I'm not necessarily using it for cardiac output calculation, which is what is generally taught for, but rather just VTI on its own, and I'm going to talk about why. But in essence, you put your pulse wave Doppler right proximal to the aortic valve, and then you got this Doppler, the envelope here, and then you trace it. It's kind of not a very good trace that I did here, but that's the idea. You trace the Doppler waveform, and then that will give you a number in centimeters, and then you can use that to calculate cardiac output. So we'll remind ourselves how we do that. So to me, it sounds sort of like a little bit scary when you start talking about VTI and kind of the physics of it, but it's really not, like once you think about it, it's actually not that complicated. So if we remember what the pulse wave Doppler does, it is essentially a recording of velocities over time. So essentially, if you think about it this way, the velocity goes up to a maximum point, and then it goes back down. And then the next cycle is again, velocity goes up, and then it goes back down. And so by tracing this Doppler envelope, what we're doing is we are calculating the area under the curve. And so that's an integral calculation. So going back to the years of algebra, many years ago, we remember that by tracing something and calculating the surface area, this is essentially what we're getting at. And so the velocity over times time is centimeters per second times second. So the result of this VTI is actually a distance. It's a centimeters. So the VTI represents the distance traveled by a column of blood in one cardiac output time. So based on that, so you can figure out the VTI and then thinking that the LVOT is like a cylinder and using the surface area of the aortic valve, the cross-sectional area, you can calculate the stroke volume. And so this is the basis of calculating stroke volume via Doppler, and that has been used in adults quite a bit. So VTI times cross-sectional area of the aortic valve will give you stroke volume, and then multiply by heart rate, and it'll give you the cardiac output. The problem is that this relies on accurate calculation of the aortic valve diameter. Now in adults, it's not so complicated because generally this in adults is about 2 centimeters. I mean, you can have a little bit of variation, but you're not going to be too wrong if you say 2 centimeters for the aortic valve diameter. However, in kids, obviously the dimensions are all over the board. And so when you think that the LVOT area is the radius square, then if you make a little bit of a mistake with calculating the annulus here, and you square that, the error is going to be much larger. And so this is an example in adults of doing that. You put a pulse wave Doppler here, you get this tracing, and you trace it. That's your VTI. And then times the area of the aortic valve, and then you get your stroke volume. So caveats with that. This assumes homogeneous velocity patterns throughout multiple cardiac cycles, which is not true. Also, you assume that the aortic valve annulus has a circular shape, which even in adults is not necessarily that true, and in kids, especially with congenitals, is also not exactly true. And then, like I said before, small errors in the measurements of the aortic valve diameters are squared, resulting in large errors in cardiac output calculation, to the point where it's only a lukewarm enthusiasm for Doppler-based cardiac output calculations in general, and then some cardiologists, including the ones where I work currently, and actually the ones where I worked before, would say that this is like almost contraindicated. There's so much room for error that you're better off just not bothering. I don't know that I'll go quite that far, but it's not a slam dunk. It's not like, oh, let's just get cardiac output, because if it were, we would be doing this all the time, and it would be much easier. But it's pretty hard to get it right. However, going back to the VTI, there's normative values for VTI published, and I put the reference here, Pediatric Cardiology 2013. And so this is why I'm using more just the VTI, because I have learned sort of in general that in, say, the newborn population, if you're somewhere between 10 and 15, you're probably good. And it kind of grows, it goes up with time, and then it sort of levels off around 2-3 years of age. So in general, in the first year of life, if I'm 15, 18, then I know it's good. And then a little bit older, if I'm anywhere between 20, 25, then I have nothing to worry about, at least from a pure stroke volume perspective. So this is a quick and dirty thing to do if you're really not quite sure about the function of the ventricle. You get this VTI, and it's very useful to at least orient you to, oh, this is pretty bad if the VTI is less than 10, or if it's between 10 and 15, it's more reassuring. And if it's more than 15, it's really kind of reassuring as an etiology of this, is this cardiogenic shock or not? Of course, there's pitfalls, like with anything. That's what I'm talking about today. You can have suboptimal image quality. If you put your pulse wave Doppler gate too low, then the VTI will be falsely low, because the blood converges from the LVOT towards the aortic valve, and so the velocity increases as it goes through a narrower portion, which is the aortic valve. So if you put your pulse wave a little bit too low, then of course the velocity would be lower, and then you think, oh, the cardiac output is lower, but it's not. It's just really you're too much below the valve. You should be right at the top, right below the valve, exactly where the leaflets come together. And then you can have poor tracing, and I'll show some examples of where that could be, where you would think that it's much lower than it actually is. If you have respiratory pathology, especially in young kids, because their annuli are so small, the total annulus in, say, a 6-month-old aortic valve is like 1 centimeter. Well, if they're breathing really hard, they have bronchiolitis or whatnot, it doesn't take much. I mean, if you were like 0.5 centimeters movement of the heart back and forth as their chest moves, your pulse wave is almost out of the aortic valve area. So you can get the impression that the VTI varies a lot with breathing or whatnot, when in fact all that's doing is the pulse wave moves in and out of the aortic valve structure. And so especially in kids, it can be difficult to get it right. And of course, improper alignment, which I'm going to talk a little bit about because it's important. So this equation I had to look up. Of course, I'm not going to remember that kind of stuff. But what's important is that the angle of insonation matters. And so for Doppler assessments, we want to be as parallel to the blood flow as we possibly can, because the Doppler shift, so the velocity that we're measuring, is dependent on cosine of this angle of insonation. So the lower the angle, the lower the cosine is. So if the angle is 0, which is what ideal is, the cosine is 1. Whereas if its cosine is closer to 80 is 0.17, if it's 90 is 0. So you're not going to see anything. And so, but you can see it's an exponential curve. And so if you have angles up to, say, 30, even up to 60, people say, the error is not that much, because the cosine up to 60 is up to 0.5, even though I would say that's also significant. But beyond 60 degrees, then the error goes up so much. And so this is important. So we have to align our Doppler beam with best as we can to the direction of blood flow. So for example, in this picture, this is upside down because this is from adult. So LV, RV here. So this is the Doppler beam that they had, and they had a pulse wave placed correctly right below the aortic valve, right at the tips. But the direction of the blood flow, so through the aorta, is here. So that was their angle of insonation. So it's about 30 degrees or so. Oops, sorry. So that's not too bad. It's not perfect, but it's not too bad. Whereas here is another example. I took this from this channel here, which is pretty great. POCUS, ran by a Canadian lady. Very good. So you can see here that their angle of insonation comes this way, whereas the angle where the blood flows through the aortic outflow is this way with the red. And so the angle is, it's not that bad. I mean, it's still less than 60, which is considered the top number, and you still have a falsely low VTI. If you look here, their VTI was 6. So for an adult, that's deadly. But so even though this patient, still had a low VTI, it's not like this patient was normal. His VTI was probably around 15 or so, but you can get significant underestimation of VTI if you don't have a good alignment with the direction of the blood flow. So that's another caveat to remember when we're using VTI to try to figure out where the cardiac output sits. Moving on to RV function. RV function is difficult. In my opinion, is more difficult than LV function. And so even though I was looking at the lectures and I saw talking about fractional area change and TAPSE, and I think it's really hard to apply those things and to do it well. And so generally we're left with eyeballing the RV, and that's also difficult. So here is an example, right? When you look at this, you say, oh, the RV is fine. And it wouldn't be wrong necessarily to say it's fine. But one thing to remember is that, and that's something that one of my mentors in Canada taught me, the RV should look snappier than the LV, provided that the LV function is normal, of course. And so if you look here, the LV is banging away here. And here is the same. It's banging away, whereas the RV is going, but it's not quite as snappy as the LV. So just looking at this, I would say the RV here is either low normal or mildly depressed. It doesn't matter what you call it, but it's not quite right. And then the other thing is that the RV is slightly I don't know if it's bigger, but similar size to the LV. And so that is another giveaway that something is not quite right with the RV. Incidentally, this was a repaired canal. You can kind of see the crowding here under the LVOT. So that's the usual appearance of the LVOT in a repaired canal, but that's not necessarily important. It's just in case you were wondering why the mitral valve is so crowded there. And sometimes in patients that have poor windows, it doesn't matter to get like the nice four chamber apical view where you see all the four chambers. What it matters, you can just concentrate on the chamber of interest. So for example, here, I don't even see much of the LV, but I do see a great image of the RV. So that can be good enough. And again, as a reminder, if you can't see the right chamber, you move more towards the right or the middle of the patient. If you cannot see the LV, you move a little bit more towards the left or the lateral side of the patient, which to me initially sounded counterintuitive, but it actually anatomically it works. Okay, this is sort of an I mean, it doesn't happen very often to see something like this, but this was a real case in the cardiac ICU with Riley, where I was before, where we had this kid, it was repaired, I think it was a TET repair, and you can still see the RA line here sticking in the middle, and he was doing fine, and then he wasn't, and he actually had a short arrest, and then we got a POCUS after, well, actually it was an echo, this is an echo clip after that, and then you can see that he has a big old Goomba clot in here, and it's probably coming from the RA line. You can kind of see it around the RA line and sort of plopping in and out the tricuspid valve, and possibly some clot in the mural RV. I'm not so sure. So you can see on this clip, you know, he's fresh post resuscitation, but you can see the RV function is not happy at all, and you can kind of see it sort of moves, but not so great. So that's just I put this because it's sort of interesting, but it doesn't happen very often to see something like this. Okay, going through RV pressure function estimation. So again, RV function difficult to assess appropriately at first impression. It looks like this RV is fine, but then again, when you compare it to the LV, you can see that the LV moves a lot more snappier than the RV, which is not normal. So the RV should be snappier than the RV because it ejects against a lower pressure system, and the way it contracts is not so much circumferential like the LV, and so it should look snappier than the LV. In this case, it does not. So that's the first indication something is not quite right here. This is another canal repair patient. And so looking at tricuspid valve regurgitation, again, there's controversy. Should we do this as a POCUS? Should we not? Is it just a preview of the cardiologist? I think it's there's always opinion about that. But if you do it, I would caution, you know, the color here. Some of the machines cannot increase the Nyquist limit as much as you should. So for example, here, and unfortunately I cut it off because I wanted to make the video smaller, but the Nyquist limit, at least on the Sonosite machine, does not go above 75. And sometimes you need more than that. So you can, by having more color bleeding, you can exaggerate the degree of the tricuspid valve. And so you have to be very careful when we do POCUS to not overestimate the degree of regurgitation just based on color, because if you have too low of a Nyquist limit, then the color will bleed and would look a lot worse. But in this case, I would say this is probably moderate to severe TR, because you can see where the jet starts is pretty wide base, and then it hits all the way to the back of the RA. And then calculation of RV pressure can be tricky. So this, you know, you put your pulse wave Doppler, sorry, your continuous wave Doppler through the tricuspid valve, through the TR, through where the jet is most obvious, and then this is what you can get, right? So it's not super obvious where do I put my point to calculate? Am I put it here? Am I put it here? You know, an echo tech, a very smart echo tech, used to tell me, do not count the whiskers, do not count the whiskers. So okay, So where exactly? Maybe here. So the books always show this nice crisp picture of a Doppler waveform that is perfectly round, and it's just on a background of black, and it's a nice white gray, and it's amazing and easy. But in practice, this is what you get. And this is the same patient. Again, these are the whiskers down here, so you're not supposed to catch the whiskers, so you kind of come here and measure here. So it can be tricky. And then here, for example, is an artifact from mechanical ventilation, right? That the kid was breathing hard, and so you actually have this apparent Doppler um, um, image from her breathing. Obviously, we should not catch that. But regardless, the patient does have pulmonary hypertension, but it can be, and people can get sort of upset because you say, oh, I did a study and the RV pressure was systemic. And then the cardiologist will come next day and then get better images and then say, oh, no, you don't know what you're talking about. It's only half systemic. So one, there's a subjectivity involved. Two is what the condition of the patient is, sleeping versus agitated versus what else is going on. And also is how well you can catch the jet, because some patients don't have a lot of TR. And so if you catch a jet that's sort of triangular and partial, you cannot say what the arbor pressure is. You can say it is at least that. So I've had a situation where I suspected pulmonary hypertension, but the TR jet was small enough or I couldn't get it. So all I could get is a TR jet, a pressure of 20. I knew that wasn't right. Am I going to think it's 20? No, I can't. I'm not going to think that. I'm going to say I cannot obtain that. And all I can say it's at least 20 plus RA pressure, not very helpful. So sometimes you cannot assess by TR jet, even if you have a TR jet. And so then you have to move it to other more advanced techniques, which I did not. I don't think those are part of POCUS, honestly, so I did not go in through those. Okay, moving through the last sort of big chunk of stuff that I'm going to talk about, pericardial effusion and caveats and assessment. So first we have to be sure it's effusion around the pericardium or in the pericardium and not something else. So the most things that we can confuse it with is pleural effusion. Pericardial fat, not so much. This is more like in big adults, but it's up there published. Also, you can confuse the fluid with clot, and I've had a situation, a fresh post-op that was doing very poorly. Physiologically, it was like a tamponade. We put the probe, we couldn't see anything. I don't see anything. And then when we looked a little bit closer, we realized it's actually fresh clot that looks almost solid. So you can get fooled by thinking it's no fluid. It's not fluid, it's fresh clotted blood that physiologically does the same thing, which is tamponade. Another interesting bit is that, especially in post-op patients, the effusion is not circumferential. It can be localized, usually in the back, around the LA. And so that can be equally dangerous because, and even more, because you don't see effusion around the whole heart, but it's localized around the LA posteriorly. So unless you're really good at looking everywhere, you may miss it. And then the other piece I'm going to touch on is the functional significance of the effusion. Specifically talking about tamponade echophysiology, understanding that tamponade is a clinical diagnosis, but it surely helps to have echo findings that go with that before you stick that needle in. So first of all, location. So I took this from an article, and I apologize, I forgot to put the reference where I got it from. But this patient had both a pericardial and a pleural effusion, and it's very helpful when you can catch the descending aorta. You show it really well. What's interior to the descending aorta is usually pericardial effusion, not usually, all the time, pericardial effusion, and what's behind the plane that goes through the descending aorta is pleural effusion. So that's a very useful distinction between the two. And you can have both at the same time, like in this case. Pericardial effusion versus ascites can be complicated to see. This is, so this is the article I took the previous picture from. So this patient had ascites, and you can actually see the diaphragm here, and that is kind of a giveaway that this is in the abdomen, not the diaphragm, the ligament of the liver, the falciform ligament. And so by seeing that kind of floating in there, you can tell that this is in the abdomen and not around the heart. But it can be pretty tricky to see. And then this is pericardial fat here. Unless you're dealing with big people which we rarely do in the pediatric world. That's not going to be a thing that will pop up very often, I don't think. So the functional significance of the fluid that you see. So in order to call it tamponade, or suspicion of tamponade, I should say, the most common and useful thing that you see is diastolic collapse. And in order of frequency, you will see diastolic collapse of the RA, and then RV, and then LA, and very rarely LV, which I have not seen that. It's important to realize that when we're talking about diastolic collapse of the chamber, it has to be the diastole of the chamber in question. So if we're talking about diastolic collapse of the RA, it has to be in the diastole of the RA, which is the systole of the RV. And so the IV valve needs to be closed. And that I'll show some videos where that can be confusing, because it can look like the atria are kind of fluttering, collapsing, but unless you can time it and say, okay, this is actually the diastole of the atrium, where the atrium should fill. So instead of filling, it kind of collapses. That is what we're looking for. But if you look at the systole of the atrium, then the atrium can in fact have a movement of coming in during its systole. So it can look like it's collapsed, but that's not what we're talking about to say collapse concerning for tamponade. Caveat here, absence of collapse. When you have significantly elevated RV pressures, like pulmonary hypertension or RV pressure increase from another cause, they may be stiff enough and pressurized enough where they will not collapse, even with a large amount of fluid. The other thing that you can look for, and is quoted, is plethoric IVC with minimal variation. I'm going to talk about how that is pretty, I mean, when you see it and everything else clicks, is helpful. But to me, again, there's so many things that can make the IVC look plump with minimal variation, that to me, that's not really super helpful. And then the last part is excessive variation of the inflow pattern from the tricuspid valve. So more than 40% for tricuspid and more than 25% for the mitral. That is very useful if you see it, but it's only valid for spontaneously breathing patients. And so for intubated patients, it doesn't really help to have it or don't have it. It's kind of hard to know. And then it is unclear applicability when you have anything other than 2V normal anatomy, this inflow variation. So for that reason, I think that is sort of like, if you have a spontaneous breathing patient, you have excessive variability, you have a lot of diffusion, then yeah, it's good. But short of that, it doesn't really help that much. So looking at diastolic collapse, so this is a slam dunk. I mean, this is not hard to figure out that this is a problem. But again, when you look at the heart, just sort of see here where it is collapsed, right? It's here, right? Where the AV valve is closed. And so that tells you that this is true. It's a true diastolic collapse of the atrium. And here is the same thing, but you're looking also at the aortic valve here that is closed, right? So we are focusing our attention on the LA, right? Because in this picture, we do not see the LA. And so when the aortic valve is closed, the ventricle is in diastole, and so therefore that's atrial systoles, and so the atrium is okay to be a little bit collapsed. So I have to slow it down and kind of think through it to be sure that I see the collapse truly in atrial diastole and not in atrial systole. This is a fake diastolic collapse. And I say fake because, yes, it happens. I mean, you can see how the atrium flutters here, but then the collapse, and I slow it down here, happens only during the opening of the tricuspid valve, which corresponds to the true systole of the atrium. And so that does not count. So yes, the patient has an effusion, but this is not true diastolic collapse of the atrium. This is interesting. This is a more advanced case of RV diastolic collapse. This patient has multiple things wrong with him. As you can see, he's got a mechanical mitral valve. He has a large circumferential effusion with some fibrinous strands. So this patient overdosed on coumadin accidentally and bled into his pericardium. And so you note the RV diastolic collapse here. And it's during when the aortic valve is closed, so during diastole. So that is what we're looking for. Collapse of the chamber during its diastole and not during its systole, which then it will shrink with contraction anyway. It's hard to know what to make of it. Going through IVC with no variation. So here you can see an IVC that doesn't really do much with breathing. It sort of stays plump, and you know it's plump because you can also see these dilated suprahepatics. You're not supposed to see them quite this big. But interestingly, notice this patient has no effusion at all. And so, and this patient, because I know who it was not fluid overloaded either, which is the other place where you think about plethoric IVC that does not respond. This patient had diastolic dysfunction of their RV with a lot of TR, and so yes, it can be helpful, but there's so many fake outs that I would leave this sort of as a extra if you wanted to just look at it, may be helpful, but I wouldn't put too much stock in it because it's just too confounded. And this is an example of a patient with IVC and true tamponade. And then you can see here that the patient did have, that's the opposite, right? So the patient did have some respiratory variation. Does that mean it's no tamponade? No. I mean, there's a large fluid effusion here, there's a lot of pericardial effusion here, and the patient did have other signs, clinical signs of tamponade. So even though there is some variability with breathing, I just don't care too much about it. Maybe the patient was dry and that's why they have a little bit of variability. It doesn't even matter. But my point is here, there's a lot of false positives and a lot of false negatives with IVC variability with breathing, such that I don't really think it's super helpful. And then fluid status assessment, there's a lot to be said there. All the pitfalls roll into one. But I did talk about this last year, and so I'm not going to go into it because I don't want to repeat stuff that I said last year. And so to conclude, I'll say that POCUS doesn't have to be perfect to be useful. I agree, but it has to be good enough. And so in order for us to be good enough, we just have to keep at it and just try to get better every chance we get. And that's it. Thank you.